Hi everyone, I am Dr. Rashmi Roy, thyroid surgeon at the Hospital for Endocrine Surgery. Thank you for joining. I'm just going to just let you know a little bit about myself for those of you that are new to the live Q&As. So, like I said, my name is Rashmi Roy. I'm a thyroid surgeon here at the Hospital for Endocrine Surgery. I only do thyroid surgeries. I did my training, I'm originally from New York, and I did my training at Columbia University and then my fellowship in endocrine surgery at Johns Hopkins Hospital in Baltimore. I then went up to Princeton, New Jersey, where I had my own practice doing thyroid, parathyroid, and adrenal surgery. I was there for about 8 years before I was recruited down here to help build the thyroid program. And I've been here at the Thyroid Center for about 7 years. And we have grown this program to be the highest volume thyroid surgery center in the United States. So these questions there have been several questions that have been sent in already. If you have any questions that pop up, then please write them in the comments, and then I'll try to get to all of them. So without further ado, the first question is it possible to have thyroid cancer even if your thyroid function tests, your TSH, T3, T4 are normal? So this is a great question. I get this question a lot from patients that I see in-person evaluations, and patients are just almost flabbergasted. They can't believe that they have a thyroid cancer when their annual blood work, their annual thyroid tests are all normal. And so the fact of the matter is that absolutely you can have completely normal thyroid function tests and still have thyroid cancer. In fact, you could have thyroid cancer that has completely spread to the lymph nodes in the center of your neck and the side of your neck, chock full of cancer, but your thyroid tests are normal. So that's not meant to scare you at all. It's just meant to empower you with information that don't fool yourself. Just because your thyroid tests are normal doesn't mean that you can't possibly have thyroid cancer. So it's really important. I think that you should do, just like women do self-breast exams, you can check your own neck with your own exam, just feeling for lumps and bumps in your neck area. I actually have a video on my YouTube channel that explains exactly how you can do that, just to be aware of your own body, and so that if a lump or bump does show up, you know to get an ultrasound. Also, you can get ultrasounds from your primary care doctor or your OBGYN if you're experiencing any symptoms that would be able to identify a nodule or a thyroid cancer. Okay, next question. I'm confused about pseudo nodules from Hashimoto's. If my nodules are consistently there yearly, then it cannot be a pseudo nodule, correct? So, correct. So this is a good question as well. So Hashimoto's inherently causes these pseudo nodules. So Hashimoto's is an inflammatory disease of the thyroid gland that just kind of causes flare-ups, and so you get this very lumpy, bumpy appearance of your thyroid on ultrasound. And so some people, if they're not experts in looking at thyroid ultrasounds, will call something a nodule when in fact it's just kind of a lumpy artifact of Hashimoto's disease. So when you get an ultrasound, let's say today, and you call it a nodule, but then you get another ultrasound in 3 months, all of a sudden this nodule has disappeared. Well, it hasn't disappeared, it just wasn't a nodule in the first place. It's what you call a pseudo nodule. But if you get an ultrasound and it has this, let's say 1.5, 2 centimeter nodule on the right side of your thyroid gland, and it's there now, and it's there in 6 months, and it's there in a year, and it's the same position in the thyroid, then yes, so this is a nodule. And if it does have suspicious characteristics such as increased blood flow or vascularity, microcalcifications, irregular borders, things like that, then you should definitely get a biopsy of this nodule, because you could be harboring a thyroid cancer as well as having Hashimoto's. So important, if you have Hashimoto's thyroiditis, to always get ultrasounds and compare your previous ultrasounds with the current ones. Okay. Hi, Dr. Roy. Can you explain how you decide when a nodule should be removed even if it's not cancer? So Many patients have thyroid nodules. As we get older, thyroid nodules are more and more common. Just because you have a thyroid nodule does not mean that you need surgery. In fact, 95% of thyroid nodules are benign. But there are indications for thyroid surgery if you have a thyroid nodule. So those indications are, number one, is this nodule suspicious for a thyroid cancer? Meaning, have you had an ultrasound that shows that it's atypical or suspicious or a malignancy? Clearly, those nodules need thyroid cancer. This question is specifically, when should it be removed if it's not a cancer? So it should be removed if it is large. So if it is over 4 centimeters or larger, that's the indication that this should be removed, that half of your thyroid should be removed, not just the nodule. And the reason is because as these nodules get bigger and bigger, biopsies become unreliable. So it's like putting a needle into an apple, you're not getting a good representation. So even though you get a benign biopsy, it's possible that you're hiding a thyroid cancer somewhere within that nodule. So once a nodule is 3.5 to 4 centimeters or larger, that half of the thyroid should be removed. So size is one characteristic. And then the other characteristic is compressive symptoms. Is this nodule, maybe if it's not large, but it's still causing you symptoms, then for symptomatic relief, that portion of the thyroid should be removed. So compressive symptoms are trouble swallowing, kind of clearing your throat a lot because you get this tickle on your windpipe or in your throat, a cough when you're not sick, kind of choking when you're swallowing like bread or steaks, or difficulty swallowing pills, tightness when you lay down, kind of feeling a thumbprint on your windpipe. So those are all compressive symptoms. So you can imagine a mass pushing on your windpipe or your esophagus, and those are the symptoms that are typical for thyroid nodules, and that would be another indication to have thyroid surgery. The last one I should mention is if this nodule is a toxic nodule, so if it's causing too much thyroid hormone, so making you hyperthyroid because of a toxic nodule, that would be another indication for surgery. Okay. I was diagnosed with a multinodular goiter over 10 years ago, and then with Hashimoto's by a different doctor a few years ago. Is it possible to have both? Absolutely. So you can have a multinodular goiter, meaning a large thyroid that has multiple nodules, it's enlarged, and then develop Hashimoto's. The two different things, but both can happen and coincide at the same time. Or you can actually have a goiter that arises from Hashimoto's. So this is called a Hashimoto's goiter, meaning the Hashimoto's has caused your thyroid to be enlarged. So they can exist separately, they can exist together. One does not necessarily cause the other, but you can have both. Hashimoto's, for the most part, can be managed with medication. There's a subgroup of patients where surgery is very beneficial to Hashimoto's patients. A multinodular goiter can be watched if it's not causing you symptoms, if it's not large, but if you have large nodules, it's causing compressive symptoms, it's visible, it's palpable, then surgery is your best option. What are the risks of leaving a large goiter in place if it's not causing symptoms yet? So I see patients, obviously, as the Goiter Guru all the time with very large goiters. And my question to them is always, what have we been waiting for? What are we watching? What are we waiting for? And so it's true, some patients have this large goiter and they don't have symptoms because this goiter grows so slowly over years that you kind of get used to the symptoms. If you had a normal neck and then all of a sudden you have this goiter, you're going to feel the acute symptoms. But the gradual growth of it, some patients don't experience symptoms, so they just kind of let it grow and grow and grow. So the risks of leaving a large goiter in place is that it can grow below the collarbone, into the chest cavity, so it's a substernal goiter. It can grow to the point where some surgeons won't be able to remove it without opening up your chest. If you are one of those people that have been told they need their chest opened, please contact me because most likely I will be able to get it out without opening up your chest and just with a neck incision. But the risk is that it will just get bigger and bigger. Eventually, it will cause you symptoms. You may need a bigger operation than you would have if you got your goiter out earlier. And you could be harboring a thyroid cancer. And so thyroid cancers can, it's not common, but it can invade the nerves to your vocal cords. It can invade surrounding structures. So surgery is always better when you get it done earlier rather than later. Can a person become pregnant after their thyroid is removed? So absolutely. Many women ask this question. They're scared, of thyroid surgery because they want to have a family or they want to have more kids. So yeah, absolutely. If I remove your whole thyroid gland, you'll be placed on thyroid hormone replacement therapy in the form of a pill, Synthroid, levothyroxine, Tirosint, combination therapy. They're all different types of thyroid hormone replacements. So as long as your thyroid function is normal, then absolutely, it doesn't change your chances of getting pregnant or your fertility. So that should not be a reason to put off thyroid surgery if you need it. Can having multiple thyroid nodules be a sign of cancer, or is it more common for cancer to show up as a single nodule? So it's a good question. I don't think that there's a clear answer to that. Obviously, the more nodules you have, statistically, more likely to find cancer in multiple nodules than just a single one. But it really just depends on the characteristics of the nodules. If you have multiple nodules, but they all look benign, or you've had benign biopsies, then you're going to have a benign multinodular goiter. If you have a single nodule and it's super suspicious on ultrasound, then it's more likely to be a thyroid cancer. So it doesn't really, the number of nodules doesn't really increase your risk. It's just how suspicious that they are on ultrasound. But if you do have a nodule, the best next step is for it to get biopsied. Okay. Hi, Dr. Roy. What's the difference between a thyroid cyst and a nodule? Should cysts be removed? So the main difference between a thyroid cyst and a thyroid nodule is that a cyst is fluid filled. So it's filled with basically just fluid, as opposed to a nodule that has the solid component of, it's a solid nodule. And so there are nodules called mixed or complex nodules. So that's nodules that have a cystic component and a solid component. Thyroid cysts, for the most part in the thyroid, are usually benign. Thyroid nodules that are solid are more likely to be suspicious for a thyroid cancer than a thyroid cyst. Thyroid cysts don't necessarily need to be removed unless they're causing you symptoms. So you can get very large thyroid cysts in the nodule that cause compressive symptoms. If that's the case, then surgery would be recommended. Some people get aspiration of the cystic fluid, but inevitably what happens is that fluid reaccumulates. But you could certainly try that as a first line of option, is just aspiration of the cyst. If it doesn't recur, great, but most likely it will recur, and then surgery would be indicated to remove that half of the thyroid gland. But something to not be confused about, even though this isn't part of the question, but a cystic lesion or a cystic mass in the side of your neck, that is really what we call a cystic papillary thyroid cancer until proven otherwise. So because in the side of your neck are lymph nodes. So cystic lymph nodes are often mistaken for benign lesions, but it should always be in the back of your head that it could be a cystic papillary thyroid cancer. So if you have a cystic lesion in the side of your neck, you should get a thyroid ultrasound to see what's going on in your thyroid gland and make sure that they're not related. Okay. Can Hashimoto's cause your thyroid to shrink over time? My recent labs are normal, but I feel worse than ever. So yeah, Hashimoto's, chronic Hashimoto's, it's this inflammatory disease. Over time, you get this shrunken, fibrotic, scarred-in thyroid gland. And that's just the natural history of what the disease does to your thyroid. Your labs can be normal with Hashimoto's disease and you still feel awful. And so these are the patients that actually benefit from thyroid surgery. So there's a small subgroup of patients where surgery is very beneficial for Hashimoto's patients. For the most part, Hashimoto's patients are treated medically and they do great. But I would say about 10 to 15% of patients benefit from surgery. So those are patients like we just talked about with this question. You know, you're on thyroid medication, your labs are normal, but you feel awful. You have all the Hashimoto symptoms, and there's nothing more that you can do, right? So surgery to remove the offending gland will be beneficial. Another subgroup of patients are patients that have tried everything, you know, tried all the different medications, done lifestyle changes, gluten-free diets, and still either their thyroid numbers aren't controlled or their labs are normal and they don't feel well. So first line of therapy is medication, but when medication fails, then surgery can be beneficial. I was recently diagnosed with a toxic nodule. How is that different from Graves' disease, and what are the treatment options? Okay, so both a toxic nodule and Graves' disease are causes of hyperthyroidism. So the way to differentiate between a toxic nodule and Graves' disease, there are several different ways. So number one, you can get checked for Graves antibodies. So TSIB, TRB, so these are specific antibodies that are diagnostic of Graves' disease. If the antibodies are positive, then you have Graves' disease. If they're negative and you're hyperthyroid, then you likely have a toxic nodule. You can confirm this by doing something called a nuclear uptake scan, where it will show this nodule kind of like a light bulb on the scan, so it's a hot nodule, as opposed to Graves' disease, which is just diffuse hyperactivity of the whole entire gland compared to just a single nodule. So that's how you can differentiate it from a diagnostic point of view, as antibodies, nuclear uptake scans, and ultrasound. And then as far as treatment, so Graves' disease, there's different treatment options: radioactive iodine, methimazole or PTU, or surgery. So surgery is the only thing that's curative of Graves' disease, and so to cure Graves' disease, you need your whole entire thyroid removed. For a toxic nodule, you can do one of two things. You can actually just remove that half of your thyroid gland, so it's much more of a minimal operation. By removing that half of your thyroid gland, that removes the toxic nodule, the source of your hyperthyroidism. You no longer are hyperthyroid. Or we also offer radiofrequency ablation. So radiofrequency ablation is a non-surgical way to treat toxic nodules, and basically it is a procedure, but it's a probe that goes into the thyroid nodule to ablate that nodule so that you can avoid an operation. So we offer that here at our center as well. Two different ways to diagnose Graves' disease and toxic nodules, and different treatment options. Can you talk about what to expect with vocal cord recovery after thyroid surgery? I sing in a choir and this has me really nervous. So yes, so vocal cord, or the nerves to the vocal cord, nerve injury, vocal issues after thyroid surgery is an inherent risk to thyroid surgery. The nerves that go to your vocal cords, they lay right underneath the thyroid gland. The thyroid sits right on top of these nerves. But in expert hands, with an expert thyroid surgeon, you should wake up with the same voice that you go to sleep with. That's what we expect from our patients. 99% of our patients wake up with the same voice they go to sleep with. As far as singers, we've operated on many professional singers, opera singers, music teachers, where obviously their voice is super important to their quality of life. And so I expect you to have the same voice. I expect the pitch, the projection of your voice to all be the same after surgery. And the way that is, that we ensure that happens is safe identification of the nerves that go to your vocal cords. So you have to identify them with our own eyes. We keep them in direct vision during the whole entire operation. Their course is completely traced, so that we can see the nerves during the operation. And then after the operation, we actually stimulate these nerves with a nerve monitor to confirm their function. So the one thing that I will say that we, with opera singers, that we cannot help is vibrato. So vibrato is a technique that singers use where it really requires very small muscle movement. In order to get to the thyroid gland, you have to go through the muscles, obviously covering the thyroid gland. So vibrato may not be changed, but that's the one thing that may need some training after thyroid surgery, but we anticipate that the vibrato should come back. It just may require some training. So if you have thyroid cancer or if you need thyroid surgery, don't be scared. Just make sure that you find yourself an expert thyroid surgeon that does thyroid surgery all of the time. Next, my doctor says that thyroid issues really only affect women. Is this true? How commonly do you see this in men? Well, your doctor doesn't see enough thyroid issues, clearly. So it is true that thyroid issues, thyroid cancer is more commonly seen in women than men, but it certainly does affect men. Thyroid cancer affects women 3 times more than it does to men. So that's kind of statistically the difference, but certainly, hypothyroidism, hyperthyroidism, thyroid cancer, all of that, Hashimoto's, Graves' disease, all of that can affect men. So this is not just a female issue. If you are a man and you have a lump or a bump, or if you have abnormal thyroid levels, you should definitely be checked out by either your primary care doctor or an endocrinologist, or seek an expert thyroid evaluation. Do you treat pediatric patients, or should children see a different type of specialist? So absolutely, we operate on pediatric patients. Last week we operated on a 6-year-old, 11-year-old, and a 14-year-old. So we operate on pediatric patients all the time. So people think that just because you're a child, that you should be seen by a pediatric surgeon. And so while pediatric surgeons are amazing at what they do, I think it's more important with thyroid cancer or thyroid surgery to see a expert thyroid surgeon as opposed to a pediatric surgeon, because pediatric surgeons do all different surgeries on pediatric patients. And with thyroid surgery, you really need someone who does thyroid surgery all of the time. So thyroid surgeries in children versus in adults, it's the same operation. The only thing is that things are obviously a little bit smaller, but it's the same operation. So you need someone that does this all the time to be able to preserve the nerves, the parathyroid glands, and do the operation that's indicated not to do too much and not to do too little to cure the process. Next question. My sister had surgery for thyroid cancer years ago, and now they say it's back. Did it really recur, or is it more likely that the initial surgery missed some? Is the second surgery more risky than the first? So, you'll never really know. Is this persistent disease? Is this a recurrent thyroid cancer? It really doesn't matter, to be honest. The fact of the matter is that the cancer is still there, whether it was there or it came back, something needs to be done about it. So so I'll say in a period of time, so let's say you have a thyroid surgery and then all of a sudden you get your baseline ultrasound at 6 months, and then there's thyroid cancer still there, that's most likely persistent disease. If you've had 10 years of ultrasounds and all of your ultrasounds have been clear and now all of a sudden something pops up, that's likely a recurrent thyroid cancer. So the timing of things and your scans will give you an idea of whether this is most likely persistent or recurrent. But obviously, again, something needs to be done about it. So yeah, second surgeries are definitely more riskier than the first. Obviously, there's now scar tissue that's involved that wasn't there during the first surgery. So not only am I, trying to remove all the disease and make this the second and last surgery for this patient, but I need to dissect through the scar tissue, dissect around the cancer, save the nerves to the vocal cords, the parathyroid glands. Hopefully the parathyroid glands weren't damaged the first time around. So it's very risky the second time around. You know, we operate on patients second, third, fourth, fifth operations when they've had their previous surgeries at other institutions. So you need to have an expert thyroid surgeon if you're getting any thyroid surgery, but you know, even more so if it's a reoperative surgery. I've been told my goiter is too large to remove through the neck and that I'd need a sternotomy. Is that really the only option for big goiters? So no. So I say this all the time. If you watch my YouTube channel, Goiter Guru, if someone tells you that you need your chest opened or your sternum or a sternotomy, you know, please contact me. I can almost always remove it without opening up your chest, doing a sternotomy. You know, I see very, very large goiters where other people will not remove it. You know, very, very, very rarely there's a goiter that's going down to, you know, your liver, essentially, that I can't remove through a neck incision. But for the most part, you do not need a sternotomy. You just need an expert thyroid surgeon who does goiters all the time to be able to remove this just through neck incision. Okay. I have a suspicious nodule that needs to be removed. I saw that your center offers traditional surgery, robotic surgery, and RFA, radiofrequency ablation. How do you determine the best course of action for someone, or is that the patient's choice? So, you know, I think it's a conversation with the surgeon and the patient. So there are, you know, certain patients that will benefit from RFA versus, you know, a thyroidectomy. So, and, you know, so if you have a singular nodule that is 3 centimeters, you know, and we know that it's benign and you don't want to have to undergo an operation, then radiofrequency ablation is a good option for you. Robotic thyroid surgery, if you know, want to do everything you can to avoid an incision or, you know, a faded scar on your neck, then we'd offer the robotic approach. You know, if you have, you know, significant cancer that's involved all the lymph nodes in your neck, or, you know, or any lymph node involvement, you know, then maybe the traditional approach is going to be better for you. So it's a conversation that you'll have with us as a surgeon. We'll go over, you know, have you had previous surgeries that may make you not a candidate for robotic surgery. So there's a lot of factors that come into play, and we'll go over that with you and decide what is the best option for you. Next question. If I have surgery to remove my thyroid, is my thyroid cancer completely cured? Will I require chemotherapy or additional treatments? Okay, so removing your thyroid is not the only thing that needs to be done to cure your thyroid cancer. So here at the Hospital for Endocrine Surgery, we also do remove the lymph nodes behind the thyroid gland. And so that's what makes our cure rates so much higher than the national cure rates that are posted in the literature. So our cure rate is 99.8% for thyroid cancers, so with a 0.2% recurrence rate, where nationally the recurrence rates are quoted to as high as 20% and even 30%. And that's because the lymph nodes behind the thyroid gland are not routinely removed at other institutions. And so that's really important, because when thyroid cancer comes back, that's where it comes back at those lymph nodes that haven't been removed. So, you know, if we're removing half your thyroid gland, we remove the lymph nodes behind the thyroid gland. We actually test those lymph nodes in the operating room, and that will dictate the extent of surgery that you need. So if your lymph nodes are okay, then you're cured with 99.8% with just removing half your thyroid gland. But if we test those lymph nodes in the operating room and they have diffuse cancer in it, then we just go ahead and take out your whole thyroid gland along with the lymph nodes underneath the other side at that time. We don't wake you up. There is no second surgery. And yes, you're cured from your thyroid cancer, assuming that this is a well-differentiated thyroid cancer, you know, a papillary thyroid cancer, follicular thyroid cancer, things like that. When we're talking about medullary thyroid cancer, anaplastic, poorly differentiated, that's kind of another animal. But when we're talking about the most common thyroid cancers, yes, we will cure you 99.8% by removal of your thyroid gland and removal of the appropriate lymph nodes. And you will not need chemotherapy or radiation or anything like that. The only thing that's possible after thyroid surgery is a radioactive iodine pill. Now, a radioactive iodine pill is only indicated if we see something called soft tissue extension in the operating room, where the thyroid cancer is kind of extended outside of the thyroid gland, so we can clinically diagnose that, or on pathology if there is soft tissue extension into the surrounding structures that the pathologist can identify under the microscope, or if there's significant lymph node involvement. So significant lymph node involvement, extension outside of the thyroid gland. So those are indications for radioactive iodine treatment. It's a one-time dose that you get approximately 2 to 3 months after surgery. And we will work with your endocrinologist to give them our recommendations of if you need it and how much radioactive iodine that we recommend. Okay, next question. I've seen your thyroid screening program and wish I lived locally and could participate. Since I do not, I'm trying to be proactive about checking my own neck and pushing for a thyroid ultrasound once a year. What else do you recommend for women? So I think that those are the two most important things that you can do. I think that you should check your neck routinely, once every month or two, just kind of so you want to feel around. So your thyroid lives kind of right above your sternal notch, 2 finger breadths above your sternal notch. You should feel that area. And then you should feel the lymph nodes in your neck. Just kind of run up and down in circular motion. Feel for any lumps and bumps, see what your neck feels like. And then every month or so, when you're in the shower, when you're putting your lotion on, just feel your neck. So that's the most important thing that you can do proactively for yourself. And then also, I would ask your primary care doctor for a thyroid ultrasound, especially if you have hypothyroidism or Hashimoto's disease. But even if you don't, if you're 35 or older, ask your primary care doctor for an ultrasound. This thyroid screening program that I've been doing for now almost 3 years, we find thyroid nodules that are suspicious enough to be evaluated in 1 out of every 6 women that had no idea that they had a thyroid nodule. The only way that they knew that is by coming to one of my screening programs. We do this free screening for them. I find a nodule, they get a biopsy, the biopsy is suspicious. So we've cured so many thyroid cancers in the Tampa Bay area where patients have had no idea that they had it. And early detection is early cure with hopefully a smaller operation, hopefully not even needing thyroid hormone replacement, and just being over and done with. So feel your neck, get an ultrasound so that you can detect any suspicious thyroid nodules early on. Okay. I had medullary thyroid cancer with stable metastasis in my spine. They just found a suspicious lymph node in my neck. Would surgery or ablation be best? So definitely surgery. So surgery is the mainstay for medullary thyroid cancer if it is an operable lesion, meaning that it's not completely encasing the carotid artery or invasion into the esophagus or things like that. So if you have a lymph node in the side of your neck that has been biopsied as medullary thyroid cancer, you need a neck dissection to remove all those lymph nodes. You don't just remove that single lymph node, you remove all the lymph nodes on that side of the neck, because if it has shown up on an ultrasound, then all the other lymph nodes in that compartment of the neck can harbor medullary thyroid cancer. So you want to remove all of those lymph nodes. Obviously this has metastasized, so it has gone outside the thyroid gland. So we're not talking about cure at this point. We're talking about local regional control. So that would be the next step, would be surgery, a lateral neck dissection, but I would do that as opposed to ablation. Okay. What are the chances of my voice improving after surgery? It's currently really bad because of my goiter, but not sure if that can be restored. Compressive symptoms of a goiter can be voice changes. What I will say though is when a patient has voice changes or hoarseness from a goiter, I'm concerned that this is a thyroid cancer, okay? Because although I have seen it, just a benign goiter causing compression of the nerves can cause voice changes. It is more common for thyroid cancers to cause voice changes because the thyroid cancers are going to be the lesions that invade into the nerve, as opposed to just compression of the nerve. So I have a little bit of a red flag, a little bit of a yellow flag that your goiter is not benign, that it's a thyroid cancer. So I would be concerned about that. That's number one. If in fact this is just a benign goiter, I've seen it where it's completely benign, it's causing compression of that nerve. And so what I tell patients is that your voice will either be the same or it will be improved after a benign goiter is removed. But most likely it will be improved. If there's no invasion to that nerve, once this compression is gone, with the goiter being gone, it may not improve right away when you wake up from surgery. But over the next several months, your voice should get better, and you can do vocal exercises, singing really high and loud, to kind of work those muscles around the vocal cords, around the voice box. Yes, I would expect it to get better if a benign goiter is causing voice issues. Why would my FNA results be sent off for molecular testing? Is that concerning? So this is very common practice in today's endocrinology world. So when you get a biopsy, the first thing that you will get is a cytology report. And that cytology report is broken up into different categories. And those categories are called Bethesda categories, Bethesda category 1 through 6. So 1 is non-diagnostic. It just means they didn't get enough cells, so you have no diagnosis. Bethesda category 2 is a benign nodule. Bethesda category 6 is a clear thyroid cancer. And so everything in between, Bethesda category 3, 4, and 5, is this broad suspicious category. And so when an endocrinologist gets a Bethesda category 3, 4, and 5, they then send it off to molecular testing. So molecular testing, there's different companies, there's Afirma, there's ThyroSeq, there's all these different companies that do this molecular analysis. All that really is further risk stratifying your nodule. So for instance, a Bethesda 3 nodule has about a 15% risk for being thyroid cancer. So let's say that gets sent off for molecular analysis. They'll find some molecular combination of genetic mutations in your nodule, so that maybe bumps you up to a 50%. So instead of you having a 15% risk for thyroid cancer, now with a molecular analysis, you have a 50%. But to be honest, it doesn't change my surgical management. So I'm still doing the same operation, whether it's 15% or whether it's 50%. So we don't tend at our center to send for molecular testing because since it doesn't change our surgical management, we don't want to do tests that don't really affect our management. But most endocrinologists will do it. It's not concerning if they send you for molecular testing. It's just kind of the next step so that they can give you some more information of what exactly is going on with your tumor. But you don't need molecular testing with a Bethesda category 3 or higher. Then surgery of removal of that half of the thyroid gland would be recommended. Okay, so this is the last question. After surgery, how do patients deal with pain if flying home afterwards? So, 50% of our practice, maybe even more actually now, is out of state or international. So we have we want patients to stay in Tampa for 2 days after surgery in a nearby hotel before they fly back home. The main reason for that is that God forbid something happens after surgery, we want you close. If you're on an airplane, obviously we can't help you. But the pain after surgery is actually not that bad. Most patients don't even need narcotics after surgery. So when you wake up from surgery, the first thing you remember is an ice pack on your neck. That's the most important thing to do for the next 3 days after surgery. In addition to that, if you can take anti-inflammatories like Advil or ibuprofen, Aleve, we want you to do that around the clock, because the discomfort after thyroid surgery is really from inflammation. So that's what the ice pack and the NSAIDs are for. In between the doses of Advil, if you have pain, Tylenol or extra strength Tylenol. So most patients, that's all that they need is the ice, Advil, some Tylenol. We will give you a prescription for a narcotic just so that you have it. If your pain is more severe or if you don't have a great pain tolerance. But it doesn't prevent you from flying home. Like I said, let's say you had your surgery on a Monday, you'd stay in town Tuesday, Wednesday, and then you would fly home on Thursday, and you should be more than ready at that point to fly home. So thank you so much for sending in all these questions. It's super fun to see these questions and answer them. I will be doing more live Q&As, so please forward questions, comment with more questions. I'll address them at the next session. If you have questions or any thyroid issues, you need an expert evaluation. If you want to see some interesting videos, you can go to my YouTube channel at Goiter Guru, or you can contact us at thyroidcancer.com. Have a good day, guys.